Good morning, everyone. Today's clinical update session is sponsored by Hyperfine, and it begins now.
Good morning, everybody. Welcome to the Hyperfine morning session here. My name is Chip Truitt. Some of you know me. Hopefully, most of you don't. And I want to introduce our speakers. I have the pleasure of introducing this morning Michael Schilder. I've known him for well over 20 years, since the days of intraoperative MRI. Dr. Schilder is the director of the Brain Tumor Center at Northwell Health Institute for Neurology and Neurosurgery. He is also a longtime friend of Jackie Bello, having trailed her by 2 years at medical school at Columbia. Our second speakers are Dr. Terry Taylor. She's an internationally recognized expert on malaria and other tropical diseases, and a university distinguished professor at Michigan State University. Her colleague in Malawi, where she'll be speaking, they'll both be speaking live from Malawi, is Karen Chetcuti. She was a consulting radiologist and radiology lecturer at Kamuzu University of Health Sciences. And my co-moderator of this session is Dr. Edmund Knopp, who many of you, I'm sure, know. With that, get us on time here. Dr. Schilder, thanks for joining us, and we look forward to your presentation.
Thank you, Dr. Truitt. As Chip said, I am a neurosurgeon, so thank you for indulging me today. And you referred to the days of intraoperative MRI as being past, but I'm here to tell you that those days are not past. In fact, we're still at the beginning of that era. And that's really why I'm here today, because my interest in portable MRI began as a result of my work in intraoperative MRI. In fact, that's why I was approached by Hyperfine 5 years ago to work together to develop a next generation intraoperative MRI. So here are my disclosures. I own a really trivial amount of Hyperfine stock. I'm not being paid to speak here today, so my conscience is entirely clean. So it may not be obvious why intraoperative MRI is valuable for neurosurgeons, given the work and expense and time and effort and everything that's involved. But these are the obvious benefits of it. We can achieve surgical navigation without a separate preoperative image. Most importantly, we can compensate for brain shift. And this intraoperative photo here shows you what brain shift can look like. You can see the cortex is sunken in at least 15 millimeters from the surface. And if you try to navigate without an updated image, you can be sorely mistaken. And I had the unfortunate experience of dealing with that just last week on a patient. The perhaps most obvious indication for people in general, and neuroradiologists in particular, is resection control. If you're going to remove a tumor, you can confirm that you've removed the whole thing. And complication avoidance, so you don't go too far. And overall, you could put this under the rubric of avoiding guesswork. If you or your family member was going to have brain surgery, would you want your neurosurgeon to know what they were doing, or would you want them to guess? It speaks for itself, I reckon. And I see. I am not advancing except on the left preview thing here. So I first got involved in intraoperative MRI with what was called the Polestar. There we are. Okay, so we went a little bit, all right. So anyway, the ideal MRI will meet these criteria. So again, it speaks for itself. But nothing could be ideal in the real world. They all have different compromises from that ideal, whether it's image quality, time of imaging, the ability to do functional imaging, and so on. The question is, what are your surgical goals? So I started with this system over 20 years ago. I'd like to acknowledge the support of my mentor, Dr. Peter Carmel, otherwise known as the husband of Dr. Jacqueline Bello. And I introduced this unit to the US and to the Western hemisphere, and Dr. Truitt and I certainly locked horns enough at various venues about the merits of high field versus low field MRI in the operating room. But there's quite an ingenious device in the way it sat under a table and would rise up to take images as needed during surgery. The system was expanded. This was made by a small startup in Israel called Odin Medical Technologies. So the field strength was increased from 0.12 Tesla to 0.15 Tesla. The gap between the two magnet poles was increased enough to make positioning much more flexible. The field of view was expanded. And if you look at this image set over here, let me go back. This is a screen capture from a patient with a pituitary adenoma, and you could track the resection in time from pre-op, intra-op, and then here, and see how you really could get quite good images that really leave nothing to chance at the time. Also around this time, this startup company, Odin, was acquired by Medtronic, and then the third generation system was introduced 7 years ago. This maintained the 0.15 Tesla field strength, but shrank the footprint of the magnet without sacrificing the expanded field of view, the expanded gantry space, or the image quality. And you can see, again, this is a screen capture here, how from an axial acquisition, you can get quite good coronal sagittal reconstructions on a pre-op image with contrast in a 6.5 minute scan. And then you navigate directly on this during surgery. When all the stars were aligned, the patient was properly positioned, the coil properly placed. There was an ingenious flexible coil technology that they developed that you could operate through. And noise was eliminated. That is, radio frequency noise is eliminated from the room. This was a very useful system and a very good experience with it. So that video, unfortunately, won't play. It just shows the functionality of the system. But regardless, this is the sum of my experience with a Polestar MRI. And you can see the plurality of the patients have gliomas, had, I should say, which is no surprise. That is one of the most obvious indications, as well as pituitary tumors and a smattering of other patients. If you look at the literature on intraoperative MRI from the 90s and early 2000s, as was the case in my experience, in about a third of the time, additional surgery results from the intraoperative image, which I submit to you is a pretty substantial amount. You know, 1/3 of the time, your surgery is changed in a way that you wouldn't if you didn't have the scan. So this is an example of somebody with a glioma. This is a preoperative T2 weighted image. And there we go. You can see we could do mapping with standard instruments to identify the motor cortex. The magnet sits underneath the table. There's no attraction or ferromagnetic instruments. Remember, the poles rise up to surround the patient's head when you image, and they go back down to operate. You could dissect the tumor out normally. And in fact, in this paper from Ohio State, they showed that the concordance of the intraoperative images mapped or matched the postoperative MRI really quite well. And on the upper left, you see using the so-called compare function from the Polestar MRI, the pre-op image on the left against coronal T2. The intra-op image in the middle shows a small amount of residual T2 hyperintensity. You can use the navigation system to point to that and navigate directly to that, take it out directly through the magnet poles using intraoperative or MRI safe instruments, repeat the image, it's gone. There's just a little bit of fluid blood layering at the bottom, and that's it. Gross total resection achieved thanks to the intraoperative image. Posterior tactic brain biopsy, with all due respect to Dr. Truitt, one of the co-inventors of a very useful biopsy instrument. In fact, well, you'll see it in a second. The instrument alone is not enough for achieving an accurate biopsy. You need to know where you're getting it from at the time. Without that, you could have if you look in the literature, a 6-8% non-diagnostic rate. That's not acceptable in this day and age. Doing a biopsy with this PulseStar MRI, for me, was the most efficient and most accurate way of doing it. So here's a patient who proved to have a splenial glioma. You can see the image on the left, and there's the biopsy cannula in the lesion. The patient is positioned prone, but the images are put in the typical imaging convention. And then another image done right after the biopsy to ensure that there's no hemorrhage. These are 24-second acquisitions. And you can see some of the other examples of this just shows you the surgical plan on the lower left. And there it is. There is the device formerly known as the Navigus, now called the biopsy guide, owned by Medtronic. Thank you, Dr. Truitt. Doing surgery awake for language mapping in the PulseStar MRI. It was actually quite a simple thing to do. Again, I wish this video would play, but nonetheless, this is a patient turned to his right with an insular glioma, and a good portion of the tumor could be removed. This is the preoperative image. Sure, it's a limited field of view, but you can see the whole lesion on this T2 MRI. Partially resected, you keep going, but at this point, the surgery is stopped because he had a temporary decline in language function, and that was an absolute sign to stop the surgery. So this is our experience in awake intraoperative MRI guided surgery using the PulseStar system. And there are mixed results. In some patients, a gross total resection is achieved without any imaging, without any effect of the mapping. In others, you stop because you have a language hit and you have to avoid worsening or giving a worse postoperative deficit. In others, you continue based on the imaging, and you're bringing all the technology together to give you the best possible result. But 6 years ago, Medtronic deep sixed the PulseStar system, and it sort of reopened the question, well, can we just rethink the whole idea of intraoperative MRI? Now let's try to leapfrog over the limitations of the PulseStar. It was controlled by neurosurgeons in OR. That was great. It could be sometimes a little difficult to use, and there were a lot of noise issues that you had to deal with. And it was unfortunately priced for people who were regular customers, as it were, at a high price point. So these are the considerations when you're talking about developing a next generation intraoperative MRI. What kind of field strength do you want? Do you need a 3 Tesla MRI in the OR? Do you have to acquire DTI? Do you have to do thermometry? Do you need to do MR spectroscopy, for instance, during surgery? Maybe yes, maybe no, but these are all considerations. Very technical consideration. How does the patient get into the magnet? Who moves? What moves? And how do you deal with noise? Okay, so how low can you go in terms of your magnet field strength? Well, you can go as low as 64 millitesla. Yep, 0.064 Tesla. And here's what the Hyperfine Swoop MRI looks like. It is truly portable. It's not just mobile like the PulseStar was in an OR tethered to a computer rack. It is literally portable, as I'll show you in a bit, and you can move it from room to room if you need to. It's very easy to use. Even a baby boomer such as myself could learn to operate it on an iPad without much effort. And certainly, anyone who's used to using any kind of electronic device can learn how to use it. Perhaps most importantly, from a surgical point of view, it's self-shielding, meaning you don't have to worry about noise in the OR. And that leapfrogs over a giant problem using MRI during surgery. These images are actually a couple of years old. So the bottom row, as you see, but this is advancing on its own. So someone, if you could stop that from happening. Was that? Yeah, well, believe me, I'm checking the clock, so don't worry. The lower images are from a 1.5 diagnostic MRI. And if you compare the Hyperfine 0.64 Tesla images above, they're pretty darn comparable. You got a full field of view, and really they're not that far off. And you're going to see in a little bit that the images have gotten quite a lot better in the last couple of years. But I'll tell you, from a surgeon's point of view, the way those images look on the top, they are completely usable and useful for intraoperative decision making. Could you stop the automatic advancement? Well, someone's doing it. Anyway, this is what was happening with COVID patients. You know, some of you are masked, some of you are not. No polemics here. That's not the point, but it's easy perhaps to forget what a crisis we were in 2 years ago. I mean, it was really bad. And what a portable MRI offered was a true point of care technology, not limited to one ICU or one room or anything like that. And in particular, the ability to image patients at the bedside, including those who were too unstable for transport. And even in normal times, this is a paper that showed how patient transport from the ICU can really result in problems. IV disconnection, ET tube dislodgement, lack of monitoring, you name it. And this was the thing that kind of made me jump out of my seat when I first heard of this, actually before it was actually published. When I saw these images in March 2 years ago, I said, oh, this is serious business. We got to find a way to image these patients in our units. And this is really just when the pandemic was starting to hit New York. So we had been planning to do a clinical trial of Hyperfine MRI in our department, in our neurosurgical ICU. And I contacted my colleagues here and I said, man, we need a unit here now. So you could see here, this is the portability of the Swoop MRI. This is our neurocritical care fellow wheeling it down the hallway. And we at our peak, we had 13 COVID ICUs at North Shore University Hospital. And we went to 7 ICUs as requested to image patients. We rammed this through. We had a special COVID IRB that accommodated us and allowed us to get this study done. In this paper, we reported 20 patients whom we imaged. We ended up imaging 32 in this whole COVID series. And you could see here, this was a makeshift ICU. It was part of our recovery room turned into a regular COVID ICU. Patients had a variety of COVID problems, ventilated or not. And these were basically the sickest of the sick. Overall, we learned some nuances of how to position the patients, position the magnet. It took us about 15 to 20 minutes to prepare them for imaging, bring it into the unit and start scanning. But you can see that's a regular ICU bed. None of the monitoring is shut off. The EKG monitors, the A-line, the whatever, it's all there. That's the coil. The patients are moved into the magnet and into the coil once the magnet is positioned. And as I said, we did it in 7 ICUs. And overall, it took about 40 to 45 minutes to complete a full series of images, T1, T2, FLAIR, coronal FLAIR, and diffusion. And at our peak, we would do 4 patients a day. We could have done more, but none of this was done by anyone from radiology, no techs or nothing. It was really neurosurgery residents and fellows. I did it one day but otherwise it was clinical staff who was doing it. So even though we had more time because of surgery numbers dropping, I mean, we still had other things to do. So these are examples of a couple of patients. On the left is a patient. These are both patients who didn't wake up after sedation was stopped for a couple of days, and we were called by the ICU directors, hey, please come and image these patients. We can't transport them. So the person on the left had an ischemic stroke. The person on the right, who had a normal CT a couple of days earlier when he could be transported, now proved to have multiple hemorrhagic strokes. And this actually led to his withdrawal of care, but certainly explained, as you could see, why he didn't wake up. But anyway, as you could see, I just want to emphasize, these images are all done with everything on. No special filtering. This is because of the self-shielding of the Swoop MRI. This is the summary of our findings, and in patients who had no abnormalities. That's also useful. They're not waking up. You could say, okay, let's just hold fire and keep supporting them, and they'll come around. We measured inter-rater reliability from 3 different neuroradiologists, and some variability in image interpretation, especially with the diffusion weighted imaging back then, but overall pretty good. So this clinical experience in a real critical time it proved that this ultra low field strength MRI, portable self-shielding, can image patients in the most difficult circumstances. So to me, as an in-hospital imager for ICU patients, this is really clear, and I think beyond any question. For me, this also confirmed that this kind of technology, and what I mean this kind of, you have to adapt a device for use in the OR, the ways that I said, who moves, what moves, coils, sterility, the whole business. But we can use this technology to really develop a next generation, truly useful intraoperative MRI, but we need neuroradiologists. I've been doing this for a long time, working with neuroradiologists intimately with functional imaging in the mid-90s with Joe Malgian and Andre Halani. I'm sure you know those people. And then with the Polestar, working with neuroradiologists in different places. I could do it on my own, but it sure as hell is not going to be as good as if I collaborate with neuroradiology colleagues, and speaking on behalf of neurosurgeons in general, that's certainly the case. So hope we can all work together towards that end. Thank you.
Michael, thank you very much for that fascinating and interesting talk. We're going to save questions to the end, and there might be a slight change in the program because Chuck Stout, interventional neuroradiologist trained at UCSF from currently in Riverside, was unable to join. I have some of his material if we have enough time. But now I'd like to jump to the other side of the world, and we're going to bring on our colleagues in Blantyre, Malawi. Those of you who have seen the current issue of the ASNR, they have a paper that's been published elucidating their experience, and they're going to share with us today their experience using the Hyperfine scanner in a clinic in Blantyre, Malawi, where there were no other options. So why don't I turn it over to Terry and Karen? And guys, it's all yours.
Thank you very much. Good morning. I'm Terry Taylor, one of the end users of the Hyperfine here in Malawi. I will set the stage for our experience with the machine and then turn it over to Karen Ketkuti, who is a proper radiologist, to discuss the more technical aspects of the work. Next slide, please, Eddie. We work in Malawi, which is a small sliver of a country surrounded by Mozambique, Tanzania, and Zambia. Malawians are lovely, and the country is widely known as the warm heart of Africa for that reason. Next slide. Our work actually unfolds in Blantyre in southern Malawi at the Queen Elizabeth Central Hospital, which is the primary teaching hospital for the Kamuzu University of Health Sciences, formerly known as the University of Malawi College of Medicine. Next slide. Our focus is on children with severe malaria. And as you can see from this Venn diagram, it's a relatively rare complication of Plasmodium falciparum infections, but since there are so many of them, we still are seeing nearly 500,000 deaths a year in children with cerebral malaria, and these are predominantly among young African children. Next slide. Our work began in 1987, and we've been trying to understand the pathogenesis of this disease since then. We carried out over 100 autopsies between 1996 and 2009, really to test our hypothesis, which was based on bedside observations that these children were dying of herniation, leading to a respiratory arrest. But although the autopsy study was fascinating and we learned a lot, we were never able to really see the classic features of herniation in any of the autopsies that we carried out. And so we had to concede the limitations of the autopsy study, a snapshot of this process at the point of death. But the luminary head of radiology at Michigan State University at the time, Dr. Jim Pochin, somehow persuaded General Electric Healthcare to donate a permanent magnet to us. Next slide. So a 0.35 Tesla machine arrived in time for the 2009 malaria season, and it became immediately obvious that brain swelling was strongly associated with a fatal outcome. And the images on the right are, the top image is a normal brain in that magnet. The middle image is a child admitted on a Friday afternoon. The bottom image is the same child the next day, 4 hours before death. We would never have appreciated this process without the MR because of the logistics of the autopsy study. These children would herniate and die very quickly. We would move quickly to the autopsy suite. We would unroof the calvarium, lift it off, and then we erased all the signs of herniation that we were looking for. So without the magnet, we never would have figured out what was happening. The trial was designed to test a couple different therapeutic interventions. Eddie, if you can move to the next slide. One of the interventions is immediate ventilatory support to kind of tide kids over the risky period. Another arm is an osmotic agent, hypertonic saline, to decrease edema. And the third arm is usual care. But the critical point is that only children with increased brain volume are randomized. And the MRI is critical to identify which children are eligible for randomization. Next slide. So we embarked on the clinical trial, and then COVID hit. Just as the old MRI, which was 3 years in past its end of life date, gave up the ghost and needed a new gradient amplifier. And so the clinical trial was dead in the water. We could not get a new gradient to Blantyre in the midst of the pandemic. Randomization just ground to a halt. Next slide. Enter the Hyperfine. We heard about the Hyperfine through the clinical grapevine. A emergency medicine resident had seen a demo in the convention hall at a conference he was attending. We started the conversations with the team in Guilford in March of 2020, and a year later, the MRI was delivered to us in Blantyre. And at this point, I'll turn over the conversation to Karen Kakuti.
Thank you, Terry. Good morning. The next slide demonstrates the multi-step implementation process which one must consider when acquiring, following and planning the acquisition process of a new imaging hardware, as is seen on the next slide, please, Eddie. Now, although there are great similarities when implementing hardware in high and low resource settings, there are also some stark differences. And what we aim to do in this segment of the presentation is to share some experiences we have had with regards to implementing a Hyperfine Swoop in a low resource setting. And our low resource setting is, as Terry has mentioned, the Queen Elizabeth Central Hospital in Blantyre, Malawi. And that is what we are going to share with you now. The next slide, please. I think firstly, it would be good to indicate that in this multi-step process, the first 3 steps indicated on the next slide. The scanner traveled by air and land to reach us in Malawi. Malawi is a landlocked country, and careful and precise planning with an efficient troubleshooting mechanism had to be in place to mitigate any challenges which happened along the way. And of course, challenges did happen and we were ready for them. Challenges relating to transportation delays due to the pandemic, which was happening at the time. Challenges relating to the size of the machine, which had to be transported into Malawi, the vulnerability of the machine. And this picture demonstrates the moment the crated scanner was being offloaded onto the ground in Malawi. On the next slide, we see that the crate has now been offloaded onto the ground in Malawi. And Dr. Doug Pastel is seen in the right-hand picture. He's a pediatric neurologist in our group. And he was given the task of uncrating the scanner. That is how the scanner arrived to us. Now, we did not have any Hyperfine representatives on site. We had to do it ourselves. And if you remember on a previous slide, Dr. Pastel did have prior training and had actually gone to the Hyperfine HQ in Guildford to receive training in even how to uncrate the scanner. What tools did we need to have at the time of uncrating? You can see him using a hammer in a proper way. So the prior training was invaluable to doing this in a safe and efficient way. On the left-hand picture, you can see indicators outside on the external shell of the box, the yellow and the red stickers. Those indicated how much, what was the humidity, the temperature control inside the crate, what was the alignment like, had it been tipped over or not. So it's these little tips from Hyperfine prior to arrival of the crate, which were super important for us to know about and to have been briefed about to do this in a safe way by people who otherwise would never have known to look for these things. On the next slide, we now see that the next step was actually moving the scanner once it was uncrated from its point of delivery to its main operating hub. And it's interesting to know that we have a video showing this movement of the machine, which you can now compare to the previous presentations. And you can see some similarities, but also some differences. Because of course it is relatively straightforward to know how to move this machine after having had training in it. But in a low resource country, you have to think beyond that. It's not just moving it. You now have to think, are there any gradient slopes of more than 5 degrees, which the scanner cannot tolerate when moved? Are there any unroofed areas, which if it were to rain would pose a risk to the machine? That's not uncommon in our hospital to have unroofed areas. Is the surface that you're going to drive the machine on bumpy, or is it quite smooth? Something, again, you would take for granted in a high resource setting, but not in our own. So careful planning of the trajectory from the point of delivery to its resting place was an incredibly important thing for us to pre-plan upon receipt of this item in Malawi. On the next slide, you will now see that we have finally reached our operation hub resting place for our scanner, our main zone of use of the scanner. And now we got to the setup phase. And of course, the scanner comes with standard paraphernalia, such as the yellow safety barrier that you can see in the left-hand picture. But when you're going to implement such a scanner in a low resource country, you also have to think beyond what other challenges would we have here that we need to prepare for at this point of the implementation process. So you have seen that, for example, internet connectivity is not something we can take for granted. Electricity surges, we either have complete blackouts or huge fluctuations in electricity supply. And therefore the black box you're seeing in that picture is actually an electricity surge protector. And now we have had big radiology gadgets here which have been destroyed because of electricity surges. we certainly did not want that to happen with our Hyperfine. And so thinking and pre-planning what, how to prepare for the arrival of such a vulnerable and important hardware in our system, what else must we think to be prepared with? As I said, internet connectivity, stable internet connectivity is a bit of a luxury here. And internet connectivity is needed to transfer images from the iPad console, which the scanner sends images to, up to the cloud platform. And so we have had, before receiving the scanner, to look at the design of our building over here. What changes can we make, or have we tried to make, to try to mitigate those internet connectivity challenges as much as possible? On the next slide, you will now see our own Hyperfine in our setting here in the Queen Elizabeth Central Hospital. Now, the picture on this slide and on the subsequent slide are taken from this recently published article, as was mentioned previously in the introduction. And of course, what we are dealing with here is a brain coil. It's an adult brain coil. And on the next slide, you will see that we also have had to make some custom-made changes to the setup of this couch, this padding. Now, this would not be a resource constraint, a low resource setting challenge specifically, but you can see that on the left-hand picture, we did have to add, for example, there's additional blue foam padding. It's just to enable us to get really good quality pictures for our pediatric brains, which we were just not getting good enough pictures for using the adult brain coils, or we could better them. And so that also took place as soon as we received our scanner. And the person you are seeing on those pictures are actually a model, someone we trialed the scanning technique process on to try to better our images. It is also worth noting that our first patient was scanned 4 hours after delivery of our scanner in Malawi, a really rapid turnaround time, which no one would argue that is incredibly rapid. And so the next slide now moves on to how are we using the Hyperfine in our low resource setting. I would say there are two broad categories of patients we are using the Hyperfine on. The first is illustrated here as one case example, is the clinical service provision arm in our settings. For our patient, for any patient here in Blantyre to get an MRI scanner, they need to be transported in a minivan for a 5-hour car ride journey to the capital city in Lilongwe. And not every patient is clinically safe or appropriate to go through that ordeal. And so having the Hyperfine MRI scanner here has been instrumental and pivotal in the management of a lot of very sick children and adults, actually. This patient was found to have an extradural abscess at theatre. And this was a time when actually our CT scanner was down. It was not functioning. The patient presented very sick, with obviously focal neurological deficits. And we just had no real idea of what intracranially was going on. And in this case, the Hyperfine Swoop saved the day, essentially, and the patient. So this is the first group of patients we really are utilizing our Hyperfine on, the clinical management, clinical necessary scenario. However, on the next slide, you'll see that, as Terry has also mentioned, it is an incredibly important component in several research studies we are conducting here in Blantyre. And the interventional trial that Terry has touched upon prior to me coming to speak here is one of those research trials in which our Hyperfine determines who is eligible to enter the trial. So these are images from one patient who was actually enrolled onto the trial. And what you are seeing here are 3 images from this published paper, which demonstrate typical features that we see in cerebral malaria encephalopathy patients, all pediatric. And what they typically present with is multilobar or diffuse cerebral edema with restriction of diffusion, particularly on admission. And the next slide will demonstrate what scoring system us 3 radiologists, 1 in Malawi, 2 in the US, look at and how we grade these images on arrival so as to determine whether they're eligible to enter the study or not. So we use this grading system, a score of 1 to 8, which corresponds to how swollen the brain appears on this entry MRI. The next slide will now illustrate some examples. So for a patient to be eligible to enter the trial, they need to score a brain swelling score of 6, 7, or 8. This patient scored a 5. So essentially there is multilobar swelling, but it's not parenchymal swelling, but it's not diffuse. So that is not written, or this patient would not classify to enter the trial. So that's where the Hyperfine is so important, determining between a 5 and a 6. As we see on the next slide, this is now a score 6. You can appreciate the parenchyma is diffusely edematous, the sulci are diffusely effaced. This patient actually is now eligible to be enrolled in the trial. So there is definitely a very urgent sort of time factor from admission in the AETC, in the emergency department. They need to go to get that scanner to see, is it a 5, is it a 6, especially. But however, we also get clinically worse off patients. So on the next slide, you will see a grade of 7, where not only is there diffuse sulcal effacement, but also reduced gray-white matter differentiation. There's also some cisternal effacement. This is how we grade a 7. And then the last illustration demonstrates a grade of 8 on the next slide. And this is our worst off patients, the ones who not only have diffuse sulcal and cisternal effacement, but also cerebellotonsillar effacement, uncal herniation, cerebellotonsillar herniation. These are our worst of patients clinically and imaging-wise, and they also would be eligible to enter the trial. So these pictures serve to illustrate how pivotal this scanner has been to allow us to carry on with this trial, which so heavily relies on MRI images. On the next slide, we now reach our conclusion, and I will hand over to Dr.
Oh, we can share. I just wanted to say that we have enjoyed superb support from the team in Guildford. I don't know when they responded to us, especially in the early days. Anytime that we sent them a WhatsApp message. And as the previous speaker mentioned, this is a very easy gadget to use. I can run it. It's been very, very reliable and robust.
And I think from my end, from a radiologist point of view, I think what we have proved is that you can have such high-tech equipment operating in a resource-constrained environment like our own. It just requires that definite needs assessment before, that definite additional preparation to ensure for safe and high-quality running of the machine. And I can say that as a group, we are incredibly excited about future developments, future body parts which can be scanned, or future improvements in quality, for example, which we know will have a heavy impact on our patients here in Milan. Thank you.
Thank you very much.
Terry, Karen, thank you very much for this fascinating presentation. Michael, the same. And with that, we're going to conclude the session, just a couple minutes overtime, but to give Dr. Grossman his full time. He's coming up next. And if anyone has any additional questions or would like to see the system, see clinical images and whatnot, we're in the exhibit hall through the conclusion of the meeting. Thank you and have a good day.